Yes, we'll look at assessing the patient for BPPV, which is benign positional vertigo. Here's where we use the bench, and we're going to basically move the patient around, and we're trying to see if we can move crystals around the different canals. And we use different test positions because the canals are orientated in different planes. So that's why we put the head in different positions. I think it's important to get the bench at the right height for you. So I like the bench at about sort of mid-thigh height, so we don't sort of hurt our backs too much. Okay, patient, if you could bring your legs up onto the bench. There we go. Now, by far the most common condition you're likely to come across is posterior canal benign positional vertigo. So this is the one that you should really spend most time practicing and get used to. We assess the condition by something called Dix-Hallpike maneuver, which basically involves having the patient turn the head 45 degrees to one side and then lying backwards. Now we have the head in 45 degrees rotation because we're assessing a posterior canal, which is at a 45 degree angle to the sagittal plane. If we put the head 45 degrees to that side, the canal is now in the sagittal plane and in the plane of the bench. So you put the canal in the plane of the bench, and then any movement of the patient will be in the plane of the canal. Yep. And so therefore you will generate movement of the crystals around the canal with gravity. So we have 45 degrees. I like to face up the bench. There are various other books and people will tell you must sit at the end of the bench and you have the patient's head dangling over the edge, but I prefer to have the patient facing me so I can look at the patient, I can hold the patient's head, and Mark, you can hold my arms, you hold onto my arms, and then you can use me if you've got poor core control or feeling very unsafe. And remember, we're putting the patient into a position which may produce a big dizziness, a big vertigo. So the patient is going to feel very insecure, and if they're on a narrow physio bench, they're not going to be very happy. To save having too much extension at the neck, I quite like to have a pillow behind the patient's back so you can lean back over the pillow so you don't have to have so much neck extension. We basically drop the patient down into this position and I'm looking at the patient's eyes. And what I would expect to see at this point, if it's a positive Dix-Hallpike, would be a torsion and a upbeat nystagmus of the eyes. And I think we have a video of that we can have a look at so that the delegates can see what we'd expect. Let's have a look at it now. Yeah. Mark, if you want to sit up for now. So this is an example of a right Dix-Hallpike, and you're looking at the eyes and you can see that it produces a reaction pretty unmistakable, upbeating and torsional nystagmus. Okay. And if you see that and it settles, as this is settling there, then nothing else produces that reaction. And it's one of those rare cases where you can be 100% sure of your diagnosis because nothing else produces that reaction. Okay. And that's quite a valuable thing, I think.